Wonderful, and we're live. Good afternoon, ladies and gentlemen. We're here with the illustrious Professor Thomas Seyfried, and today we're going to be having a really interesting discussion about fasting, autophagy, and cancer, and why fasting and autophagy, of course, are so important to the pathophysiology of cancer and to the outcomes. And Professor Seyfried, it's such a pleasure to have you with us. I'll be very grateful if you could introduce yourself and your background to the listeners.
Yeah, well, thank you very much. It's a pleasure to be here and have the opportunity to share with your audience some of the information that we have in relationship to the metabolic management of cancer. We have an active research program here at Boston College where we are on the cutting edge of trying to identify the best procedures and practices for managing cancer without toxicity. So this is basically our approach. We've been working in this area for many decades, and things are starting to come together now once we have a firm understanding of the biology of what cancer actually is, knowing what the tumor cells are using to survive and grow, and then knowing how we can interfere with these processes to eliminate the tumor cells in a non-toxic way so that the patient does not need to suffer the horrific adverse effects of the types of chemicals that are presently being used to manage this disease. So this is where we are right now, and we're moving forward as fast as we can with the hope to achieve resolution or a long-term management within the next few years.
Great, thank you very much. I guess one of the first things that I would love to ask Professor Seyfried is, why has the war on cancer failed? And by failed, I mean, when the war was declared on cancer, the survival, so the kind of 5-year survival for most cancers hasn't changed drastically. So, for example, when we look at non-small cell lung cancer, bladder cancer, we're using primarily, at least in the first line and second line treatments, but easily before metastatic disease, we're using pretty much the same agents. What happened in between then and now?
Well, I think it's a process. I think you can get a more clear understanding of the development and understanding of cancer from Mukherjee's book, Siddharth Mukherjee, on the Emperor of All Maladies. I think he did a good job in identifying the fiascos that have been associated with cancer from our earliest attempts to manage this disease. It's been nothing short of a monstrous fiasco in terms of the types of strategies that have been used in the horrific surgical mutilations, the toxic, incredibly toxic chemicals, followed by incredibly toxic radiation therapies. And these have all morphed into what we have today, with the concept that cancer is a genetic disease, and therefore many of the therapies are designed to try to interrupt the development or the proliferation of these cells. So, and the concept of a war is another term that really is misleading. It came from, I think, morphed from President Johnson's in the 1960s, the war on poverty. And then, this generated a lot of particular interest. And then the war on cancer in the early 1970s under the Nixon administration, they used these terms as if we're actually conducting some sort of a war. But you're absolutely right. The progress in the challenge to manage cancer has been less than satisfactory, abysmal. The problem is that it's easy to cure small growths that have not spread into the lymphatic system or the bloodstream, what we call basically benign tumors. And these are also classified under the cancer. So it looks like, we're doing pretty well, managing, but once the tumor cells metastasize and spread through the system, the likelihood of long-term success is not much better today than it was 50 years ago. So in that regard, we haven't made any major advances in controlling those very aggressive, invasive cancers and those that can show metastasis throughout the body. So you're right. And this is our focus. Our focus is to stop these kinds of cancers.
Agreed. One of the things that I've noticed is that the pharmaceutical industry, in fact, the entire healthcare industry, particularly when it comes to cancer, is very, very big at the moment on looking for a genetic cause. So, searching endlessly for markers which may help us better stratify patients or, use a certain agent in a certain population. And so many of these markers have come and gone. I mean, some of them are still here. We have KRAS, we have EGFR, we have ALK mutations in lung cancer, we have HER2 in breast cancer. But I guess just for the benefit of individuals out there who don't quite grasp the difference between a genetic disorder and a metabolic one, could you just explain that difference, please?
Yes. The concept that cancer is a genetic disease focuses on what is thought to be the origin of the dysregulated cell growth. So if the concept is that the origin of the cancer is the result of a mutation in a gene that plays some role in the regulation of the cell growth, the abnormal cell growth, then the focus of the approaches to manage or predict or diagnose the disease is based on looking at genetic markers, either for identifying the disease or in targeting that marker with the hopes of stopping the disease. So this has become an extremely profitable area of both research at the academic level and in drug development at the pharmaceutical level. So having cancer as a genetic disease has generated enormous academic interest and drug development interest. But the problem, of course, is that it's not a genetic disease. So therefore, if it's not a genetic disease, most of the efforts in that sphere are quite useless and wasteful. And we can see this by the number of people that are dying each year from the disease. And they're saying, well, the reason we have so much difficulty is because the disease is so complex. And at the genetic level, indeed, it is complex. The disease is complex, but this is all downstream epiphenomena. We shouldn't be focusing on this. This differs from a metabolic. When we have the origin of the disease based on the mitochondrial metabolic hypothesis, this view says that the cancer starts from a defect in the ability of the tumor cell to use respiration to get energy. Our cells in our body use oxygen and respiration to generate the energy that they need to conduct the activities of those cells in each part of our body. All of our cells get oxygen from the bloodstream, and we produce CO2 as a waste product. So we inhale oxygen, and then we exhale CO2. And the waste products of respiration are basically CO2 and water. So the water in our bodies are generated with amino acid breakdown products to make urea, urine. And these are the waste products of normal respiration. The cancer cells are largely damaged in their ability to respire, so they ferment. So in order for them to grow and proliferate, they need to ferment. And this is a very primitive form of energy that existed on our planet before oxygen came into the atmosphere. So these cells are using a very primitive form of energy, and those primitive forms of energy use certain molecules that can be fermented, that is, metabolized for energy in the absence of oxygen. And that can be mostly glucose, and some amino acids can be fermented. So the cancer cells are essentially using these primitive forms of energy to survive and proliferate. Now, the issue, of course, is when the respiration becomes damaged and the cell has to ferment, the program the genetic program needed to do that are these oncogenes and tumor suppressor genes. So they are participatory only in order to get the cells to shift to use fermentation metabolites. So there's several ways you can then stop the disease. You can either track down all of these genetic mutations that are supposedly in one way or another facilitating this abnormal phenotype, or you can simply deprive the tumor cell of the fuels that it needs to ferment. And this is our strategy. It's a simple one. It's much more effective, and it can be non-toxic. Take away the fuels that the tumor cells are using to generate energy and transition the entire body off to an alternative fuel like ketone bodies that the tumor cells cannot use because they need to use respiration to get energy from ketones, and they have the defect in respiration. So our normal cells are transitioned over to a respiratory fuel, and we then take away the fermentable fuels of the tumor cells, and they can't survive. And we try to do this without creating toxicity in the body. This is an entirely different strategy than the ones that are currently used in conventional medicine.
I agree with you. And I think what is often missed by patients and physicians alike is the issue that you've touched upon a number of times, and that is the issue of toxicity. When you have a metastatic cancer of some sort, usually by this stage, this patient is already often very frail. At the very least, even if they're not frail, they're already very, very sick. They're immunocompromised. So toxicity is really the kind of key issue. And I guess what's come about from most of the trials is that the patients end up dying from the associated toxicities of chemotherapy, whether it's the chemotherapy-induced anemia, whether it's the xerostomia from the radiation therapy. All of these things cumulatively add on to negative outcomes for the patients. Yes,
that's true. And you say to yourself, why are these poor cancer patients so frail and so immunocompromised in the first place? Most people who are initially diagnosed with cancer, not all, of course, but many, look pretty healthy at the time they're first diagnosed. It's only after they begin the treatments that they become emaciated and frail.
Absolutely.
Not all, again, and not all patients, but many are, and they suffer all these adverse consequences of the treatments that they're receiving. This is not rational. Why you take a person that's has a particular kind of affliction and then poison and irradiate them to make them healthy? And thereby, the grace of God, you're supposed to survive. And if you do survive, now you're afflicted with a series of maladies that perhaps could last the remainder of your life and even shorten your life as the result of the treatments that were used to save your life. I mean, this whole situation is insanity. The issue here is, if you understand that this is a mitochondrial metabolic disease, the types of strategies and treatment processes become totally different, where we can actually kill tumor cells by making the patient healthy at the same time. The failure in this whole system is that the caregivers, the physicians themselves, the ones that are treating patients, are not trained to learn this. This is not part of the medical training. So it's not the physician's fault on this. It's the system's fault. The physicians are not trained to know how to use food as medicine. And they're not trained at how to use certain dietary procedures along with certain drugs that work synergistically together to keep the patients healthy while at the same time targeting the cancer cells. This type of training is not part of the medical establishment in the Western world. So until that changes, I don't think the whole system is going to change to a great degree.
I completely agree with you, and it's something that I've witnessed as well, that the medical training is very, very reductionistic. So it's, let's focus on a tumor and do whatever we have to do to try and get rid of that tumor, even if it's at the expense, as these therapies often are, at the expense of the well-being of the overall patients. One of the things that you mentioned earlier, which I think is very, very important, is the fuel. How do cancers fuel themselves? And then you touched upon the topic of ketosis. Just before we kind of go into that question, can you possibly expand on what exactly is ketosis, and then how does therapeutic ketosis and fasting enhance the mitochondria, at the edema?
Yes, well, therapeutic fasting, the consumption of water only, is a way to bring the body into a ketotic state. And what that simply means is that, as a species, human, Homo sapiens, we survived. Our ability to be where we are today was the result of our incredible ability to survive without food. We have, as a species, were almost eliminated several times during the various epochs on this planet. But for our ability to go long distances, long periods of time with very little food, our bodies have an incredible capacity to store energy in the form of fat. And just storing a little bit of fat can preserve muscle and keep us functional. And the way the body does that is it takes these fat molecules and they are transported from our fat cells into the circulation, and then these fatty acids go to the liver, and the liver then breaks them down into smaller water-soluble products called ketone bodies. And these ketone bodies can replace glucose, not completely, but nearly completely, as a form of energy. The brain, of course, needs glucose, and the ketone bodies can reduce the ability of the brain to use glucose. So ketones can increase cognitive awareness. The heart and the muscles become much more energy efficient when they're burning ketones. So this is a way that we can survive based on our stored fat reserves. And we have an incredible capacity. As a matter of fact, there is no upper limit on how much fat our bodies can store. Given the available foods, the obesity epidemic is the result of our historical ability to conserve fat. The problem is, for most of our existence on this planet, we were in a starved state. So our bodies became super efficient in storing energy. Now, with the industrial revolutions and the food industry developments, we have access to foods in huge quantities that we never had before. But our bodies took thousands and thousands of years to develop the capacity to store the energy. So we're getting now massive obesity epidemics as the result of a evolutionarily designed conservation of energy. So in order to, because our bodies were in ketosis for many, in prehistoric times, 10,000 years ago, before we were able to cultivate food, we were oftentimes, and this is the whole concept of the paleo efforts, bringing our bodies back to these conditions where we were using ketone bodies in sufficient amounts to keep our bodies healthy, as opposed to using, glucose. So therapeutic ketosis is simply a way to bring our bodies back to the way we actually evolved. Lowering blood sugar levels. If you stop eating, blood sugar levels naturally go down, but the liver then begins to make glucose from some of the proteins that we're no longer. So for example, if you stop eating, why would the body continue to make digestive enzymes if there's no food coming into the system? So one of the first protein groups that are used for energy would be breaking down digestive enzymes, which then go to the liver, and through a process of gluconeogenesis, the body internally can make some glucose. But this glucose is not sufficient to keep the brain active, so we break down our fats to ketone bodies. So then what we have is a combination of internal gluconeogenesis combined with ketone body synthesis to produce a new physiological enhanced metabolic state called therapeutic ketosis. And this is then brings the body into a new state of heightened metabolic homeostasis. And this is very, very therapeutic, because what therapeutic ketosis does is it causes an internal surveillance of our body. Every molecule that is now synthesized must have an important function in maintaining the health and vitality of our system. So cells that are not working properly, mitochondria within cells that are not working properly, are dissolved through the process of autophagy, and the molecules in these organelles and these defective cells are then recycled through the body for the good of the other cells that are now entering into this new state of energy efficiency. And this has been a traditional way to improve health. Most religions have a period of fasting that's associated with this. Not only is this therapeutic for the physiology of the body, but it's also therapeutic for the mind. So burning ketones brings people into some sort of a mental state, a religious kind of state that can happen through prolonged ketosis. So many of these things come together, and it's become part of our culture. In the past, I don't know if it's as effective today as it has been in the past, because we're bombarded and confronted with all these new high caloric, tasty foods. So it becomes much more difficult to do this kind of thing.
I agree. In fact, one of the things that I've often speculated is to the extent which we as humans are actually maladaptive to the industrial age. And I completely agree with you. We evolved in a situation where we didn't have a Starbucks or a supermarket in every single corner, and the ability to get an abundant supply of calories, specifically starches and sugars, was very, very limited for huge parts of our evolutionary journey. One of the things that I guess that a lot of individuals out there will possibly ask is that, let's say, for example, we have a cancer patient. In a lot of situation, these individuals are already suffering from some kind of a cachexia or possibly even anorexia, as a result of either the therapy or they're malnourished over a period of time. Now, of course, with a fast, and I've practiced therapeutic fasting, one doesn't lose muscle mass. But I would love if you could just kind of go into that process. Why is it that the individual who is fasting won't necessarily just waste away? Because that's the first thing that kind of comes to mind, and that's what often the physicians will say, that hey, if you fast, you're already quite frail, so I'm concerned you're going to be losing a lot of muscle mass here, which we absolutely don't want. How does the body preserve itself during that time?
Yeah, well, this is a very important question. I'm always asked this question: how is it possible if you take a cancer patient that's losing weight, and then you're asking that patient to stop eating? It would seem counterproductive to the health and well-being of the patient. We have to then consider weight loss in association with cachexia, cancer treatment, and therapeutic ketosis. So in the state of cachexia, this is a type of pathological weight loss. So the cancer cells are needing the fuels to drive their proliferation. What are those fuels? They're basically glucose and glutamine. Glutamine is an amino acid that's abundant in muscle. So the cancer cells will signal the muscle to release proteins that go to the liver. These proteins will go to the liver to make glucose, whereas the amino acid glutamine can be used together with the glucose to drive the proliferation of the cell, so of these tumor cells. So this is a pathological state. Interestingly enough, when you look at the blood work of a patient who is in cachexia, oftentimes you'll find that levels of blood sugar and insulin are somewhat elevated, which is kind of interesting. This is a situation that you would see in kind of a diabetic situation, where insulin insensitivity becomes an issue. Insulin drives glycolysis in the tumor cells. It forces glucose into the system. So a cachexic situation is a pathological state. It's a very unhealthy state. You compare that with therapeutic ketosis, where you have very low glucose, very low insulin, and muscle sparing. This is a very different physiological state than the pathological state of cachexia. Now, this is why ketogenic diets, calorie-restricted ketogenic diets, provide an excess amount of fat with keeping blood sugar and insulin low, and killing the tumor cells. So the very tumor cells that are eliciting the cachexic phenotype will be killed to some extent under a ketogenic diet. So initially, there will be some combined weight loss from the two dramatically different forms of energy stress on the body. In one form, it's the cachexia, which is pathological, and in the other, it's the therapeutic form in the form of therapeutic ketosis. But they will overlap at the beginning. Once the tumor cells start to die and become managed, patients can then gradually gain their weight back and reach a new healthy state. However, we must be aware of the state of the patient at the time this therapy is administered. And I agree, some patients are already too frail and too emaciated and wasted for an aggressive therapeutic fasting or something like this. So it has to be done very strategically by healthcare people, nurses or physicians that truly understand the nature of metabolic homeostasis in the body. Now, of course, there are some patients who may come in with a cachexia, but they have sufficient body stores that they can use to make these transitions. So again, it depends on the physiological state of the patient, the age of the patient. A lot of these different things have to be evaluated before one would use a therapeutic fast, a calorie-restricted ketogenic diet, or some combination of these approaches in order to bring this patient into a more normal metabolic state. And of course, we have many cancer patients who are emaciated as the result of the toxic treatments that they have already received. So weight loss for cancer patients can come from cachexia, or they can come from cachexia combined with the toxic therapies that they have been administered. So, and this then sets the mindset of the physician. Oh, we can't do anything that will compromise the weight of the patient. So you say, why is the patient losing weight in the first place? So if it's pathological, then we have to be able to correct this pathological weight loss. We don't do it by poisoning and irradiating the patient. We do it by restructuring the whole body over to a new physiological state, killing tumor cells while allowing the patient's physiology to improve. This kind of philosophy is not part of our current medical practice, as far as I can see.
I agree with you. And I guess what I would also love, if you can explain, is because of course, the human body is incredibly adaptable to multiple, sources of energy. So we can, of course, use ketones, we can use glucose, and even alcohol, can be burnt in the body for energy. But what exact kind of molecular, I guess, mechanism prevents the cancer cell from adapting to use the ketones as their own energy source when the body is in ketosis?
Yeah, well, there's a fundamental issue in cancer, and that was reported by Otto Warburg many years ago. All tumors, to one extent or another, have a defect in their respiratory capacity. This means their mitochondria. The mitochondria in cancer cells are abnormal structurally, functionally, and quantitatively. So if you look at cancer cells under the electron microscopy in the tissue itself, not cell culture. Cell culture is an altogether different issue. Cancer cells in culture, that's an artificial environment. They don't necessarily represent what goes on in the real world situation of the body. But if you look at cancer cells under the electron microscope, you can see all kinds of morphological abnormalities in their structure, their numbers, and these kinds of things. And if you do biochemical analyses, you can see abnormalities in the proteins of the electron transport chain. The lipids inside the mitochondria are abnormal in the cancer cells. All of these are indications that those cells have defects in their ability to respire. So those are the molecular. So that having that defect then means that these cells have to use an alternative energy supply. So this is the key to recognizing what the disease is and how to eliminate the disease, or at least put management. And that is, in order to metabolize ketones for energy, you have to have a good mitochondrial system because the ketones are respired in the mitochondria to generate the energy. So if the cell has a defect in the very structure needed to metabolize the ketones, it's not going to be able to use those ketones as nearly as efficiently as the normal cell. Now, there are some very indolent cancer cells that grow slow that can use ketones to some degree, but they're also dependent on these fermentable fuels to another degree. So the issue, of course, is that can you transition the body away from the state of fermentation energy to a state of respiration energy, which is ketosis? And that usually puts enough pressure on the tumor cells to kill them. Now, of course, this, in my view, cannot be done with ketosis alone, despite the fact that the tumor cells can't burn them efficiently. I think we need to use certain drugs that work synergistically with the ketotic state. That really is the push these cells right over the edge of their existence, these tumor cells, while using ketones to protect all of the normal cells in the body. This is a strategic approach that has to be done carefully, depending on the type of cancer, the patient. All of these things have to be brought into an understanding as to what kind of strategy that would be used to manage that individual. But basically, the tumor cells cannot use ketones effectively. So therefore, the higher you can get the ketones and the lower you can get the glucose puts tremendous stress on these tumor cells, and they become extremely vulnerable. This whole concept that they can transition and adapt is nonsense. The issue of they adapt, and if you have the available fermentable fuels in the microenvironment, those cells will give the appearance of adaptation when they're simply transitioning from, say, glucose to glutamine or glutamine to glucose. So there's no therapies currently being used to treat cancer patients that that target the glucose and glutamine simultaneously in these tumor cells. This is not being done today. So with the cancer cells must be adaptable. They're not adaptable. They have all these genetic mutations. How are they going to be adaptable when they have all these genetic mutations? Most of the treatments that we give to the cancer patient produces large amounts of glucose and glutamine in the microenvironment. These cells are not going to die completely if they have the available fermentable fuels. The higher the fermentation, the better they pump out the cancer drugs. They get hypoxic. The radiation doesn't work. I mean, all of the things that we're doing make no sense if you understand that this is a metabolic disease.
Agreed. I completely agree with you. Just before we go on to the next question, I would love to get your just kind of opinion on. You mentioned, for example, a couple of indolent, slow-growing cancers earlier on. Were you referring potentially to cancers such as, some kind of a slow-growing prostate cancer or Hodgkin's lymphoma? Are there specific malignancies, whether solid tumors or hematological malignancies, that may be able to grow slowly enough that they can, over time, use the ketones in their own for their own survival?
I don't think so, because again, if you're going to use ketones, you have to then generate good mitochondria.
Yeah.
And no cancer cell has good mitochondria. So the issue here is that it's a mitochondrial metabolic disease, and if you do a mitochondrial transfer, this hasn't been done in the cancer field as a treatment, but I mean the way to restore normal physiology is just replace the abnormal mitochondria with fresh new mitochondria, and the tumors will stop growing. But this is a very difficult thing to do. It's easier to deprive the tumor cells of their fermentable fuels. That's the best way, because some people are interested in re-educating the cancer cell to become a normal participant in the society of cells. And the only way that can happen is if you give them a mitochondrial transplant, and that's not going to happen anytime soon. So the best thing to do is just take away what they need to do to survive, and then provide the ketones to the normal cells, and then you can protect the normal cells from pushing these tumor cells. So that to me, at this point in time, in this day and age, that seems to be the most effective way to manage the disease and provide much longer term survival at a higher quality of life. until we can then begin to do more sophisticated manipulations in the future. But right now we have a crisis. We have too many people dying of cancer needlessly, and we need to address this in a very expedited way.
I agree with you. But one of the things that I would be grateful if you can also touch on is, how would you define a therapeutic fast? And, on a therapeutic fast, how does ketosis and the therapeutic fast work synergistically?
Well, if you stop eating, and we've done it in the lab with my students and even me, I've stopped eating for 3 days, 3.5 days. And I haven't gone 7 days, but some of my students have. And we measure blood sugar and ketones. Interestingly, females, women have a much better, it seems to be easier. They can get their blood sugars down after about 3 to 4 days of water only, no food. Their blood sugars can go down into the 2.5 millimolar, in 40 to 50 milligrams per deciliter glucose, and ketones can go up to about 3 to 5 millimolar. We've seen as high as 6 millimolar. Now this is very far from what we call ketoacidosis. Ketoacidosis is a pathological state, usually seen in type 1 diabetics, sometimes type 2 diabetes, where ketone elevations go up to 15 to 20 millimolar. It's a very deadly, very dangerous state, also in conjunction with high sugar. So you have high sugar, high ketones, another very pathological condition. Most people that don't have diabetes don't have to worry about this. People with carnitine deficiencies, there's some rare metabolic states where therapeutic ketosis and therapeutic fasting is not recommended at all. But blood work can determine whether a person can do this or not. I would say the vast majority of people, because we evolved to do this. So the issue, of course, is how low can you get your blood sugar and how high can you get your circulating ketone bodies, which is called therapeutic ketosis. If you take a calorie-restricted keto, suppose, for example, a person went on 4 days 3 days to 4 days with water only, and then transitioned off to a ketogenic diet, a diet that has very low carbohydrates and high fats, like saturated fat and monounsaturated fat, then they will be able to push their blood sugars down a little bit lower and bring up their ketones a little bit higher. And it's these states when the blood sugar is very low and the ketones are high within normal physiological conditions that the tumor cells have great difficulty in trying to survive, especially those that are dependent on glucose. Those that are dependent on glutamine can weather this therapeutic. They can weather this storm, this metabolic storm, because they're burning an alternative fuel. So that's why therapeutic ketosis and ketogenic diets will be effective only up to a certain state in managing cancer, and will not kill those tumor cells that are actually transitioning to glutamine. This is why you have to do both. But if for the normal person, the person who doesn't have cancer, or a person who would like to prevent cancer, as we said, these indolent tumor cells, if it hasn't blown up into a full-blown disease, can be killed effectively by therapeutic ketosis, because those tumor cells will be eliminated for the good of the whole in transitioning away from the glucose environment. So again, therapeutic fasting followed by a transition into a calorie-restricted ketogenic diet, and people can then feel that they're not starving. Also, the feeling of starvation dissipates with time.
Yeah.
It works better for young people. Older people have a much greater difficulty in going into these therapeutic states unless they've had practice. It's like anything else. You're running a marathon. Okay, if you haven't practiced running the marathon, it is an extremely difficult event to do. But if you've had practice and your body's in shape to do this, then transitioning to therapeutic ketosis periodically is not so difficult. It's the hard part is when you try to do it for the first time. It can be very difficult for most people. But then you can transition into you can do a ketogenic diet and bring yourself into a very high state of therapeutic ketosis.
Great. And I guess one of the things, or one of the questions that I've been asked often is, should a patient use dietary supplements during the fast? You know, the kind of vitamin C's, the vitamin D. Where do you sit on that, or where does the evidence guide?
Well, this is a very new field. We're learning things all the time. When you get your state into therapeutic ketosis and also into ketogenic diets, we're beginning to see some really interesting phenomenon. You have to realize our bodies naturally store vitamins and minerals. Our livers store vitamins, our fat-soluble vitamins are stored in our bodies. Our bones have minerals. This is why, when, as I said, we evolved to starve. Well, we're not taking vitamin supplements. We're not doing any of this stuff. All this stuff is coming out of our body naturally. Okay, of course, if you don't eat food for longer periods of time, then the body shifts from a state of healthy fasting into starvation. Starvation is a pathological state where we have depleted the available vitamins and minerals from going without food for such a long period of time. Now we enter the pathological state of starvation. And this is a line that depends on what the person's body weight is and their state of physiological health before they transition over to starvation. So taking vitamin supplements and minerals, in my view, is not necessary at all during short fasts, say up to a week or even 10 days. It's not necessary to take any vitamin supplements because our bodies have stored all of this in our fats, in our bones, in our liver. So we already have, we don't need to be popping vitamins. And the other thing, unless you go longer, obviously, if you decide to do longer fasts, the issue, of course, is, for cancer patients, popping supplements. Some supplements may be very effective, others may be less effective. One has to realize that the tumor cell, which is an inefficient metabolic system, also has a great need for vitamins. So by cancer patients taking vitamins, you have to say, is this really helping my normal cells, or is it helping the tumor cells? So because getting energy requires vitamins, and if you're energy inefficient and you don't use energy efficiently, you're going to require more vitamins to do that. So popping all these vitamins, we think that a minimal amount would be necessary because we evolved to use the most minimal amounts of vitamins and minerals to maintain health. Taking excess in a state of with a patient with cancer could be helping the cancer cells more than the normal cells. So one, again, has to be very careful and understand these differences between normal cells and tumor cells before embarking on popping all kinds of supplements. Not to say that supplements aren't good. There's evidence that curcumin can be helpful as a supplement. There are some others, and I don't think we fully yet understand the value and importance of supplements in the healthy state versus the state of cancer. So again, this all has to be reevaluated in my mind.
I agree. And one of the things I guess that I see often is the question, can a therapeutic fast and chemotherapy work synergistically? And I guess this is a question that any patient, broaching the idea of a therapeutic fast with their oncologist or hematologist will get asked. Look, I'm just not too sure. I'm thinking of starting you on chemotherapy, so possibly have initiate the fast during your drug holiday. But actually, there seems to be a lot of data that this can work really, really well synergistically together if the patient does opt to have chemotherapy, that is.
Yeah, I agree. I mean, I know the work of the Longo group. They had shown that fasting can reduce the adverse effects of some of the chemotherapy. The patients don't seem to feel as sick. I think some of the dosages can be changed as the result. So patients, does that work synergistically with the chemo? Perhaps it does. Maybe it does. Personally, I would never use chemotherapy to kill cancer cells when we can do it naturally. I would use a whole different strategy. So I would never want to put any kind of poison into my body that would create a risk in damaging in any way my physiology. So personally, I would not use chemotherapy. I would use strictly metabolic therapies, which would be therapeutic fasting, ketogenic diets, hyperbaric oxygen, a variety of other ways in which we can kill these tumor cells the same way without having to subject our body to any toxicity. But in going back to directly answer your question, yes, there is evidence that therapeutic fasting with chemotherapy seems to have caused less collateral damage or toxicity. And I know that has been observed in a number of situations.
Agreed. And I guess that, I mean, just on the topic of the kind of going back to the genetic cancers, people still try to, I guess, create an artificial separation between, okay, so we understand, of course, you know, cancer's metabolic, but some of these cancers, such as, you know, the BRCA1, you know, which is, you know, these are somehow kind of inherited genetic cancers. So I guess just for the individuals out there who've been offered or ordered to, depending on the kind of tone of their oncologist, you know, some kind of a double mastectomy, can ketosis and therapeutic fasts benefit individuals who are, you know, who've been told that they're at a high risk of genetic cancers such as the BRCA1?
Yes. Well, this is also a misconception because there are what we call direct causes of cancer and secondary causes of cancer. So, and the inherited cancers, the germline mutations that predispose people to, or let's put it this way, put people at a higher risk for certain cancers like the BRCA1 and 2 and the Li-Fraumeni cancer, P53 inherited mutations in the P53 tumor suppressor gene. These do in fact put patients at higher risk for cancer. However, are these mutations inherited through the germline direct causes of the disease, or are they secondary causes of the disease? And when you think critically, as we have, about this, these mutations are secondary causes of the disease. They're not the primary cause. Because we know that the P53 and the BRCA and all of the known inherited genes that affect cancer all damage the respiration of the cell. So those genes are encoding proteins that actually influence the function of the mitochondria. Now, why we call this a secondary cause rather than the primary cause, for the reasons that you just mentioned. Not every person who has a germline mutation will develop the disease. So there's not 100% linkage between having the gene and having the disease. This indicates that there are other factors that can influence how those genes work to determine whether or not they will damage the mitochondria or not. So now we have to say, okay, well, BRCA1, the penetrance, that is, if you have the disease, if you have the gene, what is the probability that you will have cancer? In some cases, in the BRCA1s, it could be from 40% to 70%. For Li-Fraumeni, it's higher. It's like 80 to perhaps 90% of people that inherit the gene will eventually go on. But it's not 100%. So that means that we can intervene and significantly reduce the risk of those genes actually damaging the respiration. So if we introduce a metabolic therapy to keep the mitochondria healthy and functional, the probability of those genes actually causing the cancer or contributing to the cause of the cancer goes down significantly. So people need to know this, because if it were 100% that every person that would inherit this gene would develop that cancer, then we would say that is the direct cause of the disease. But that's not the case. Now, there are some inherited cancers very rare rhabdomyosarcomas that encode proteins of the electron transport chain in the mitochondria. There is almost 100% chance that those people develop cancer. But again, the protein is damaging the respiration. The damaged respiration leads to the cancer. So this is the so it is the mitochondrial function that determines whether or not the person will get cancer. Cancer cannot happen in any cell of the body when the respiration in that cell is healthy. It just does not happen. So the key to prevent cancer is keep the mitochondria as healthy as possible. And the key to managing cancer is to kill those cells that have dysfunctional mitochondria and enhance the mitochondria in the rest of the body.
Of course, I completely agree with you. And some of the therapeutic or prophylactic options offered to people who are at a high risk, such as a double mastectomy and a hysterectomy, these seem to be counterintuitive on many levels because, of course, the person's going through a brutal surgery, and of course, it damages their immune system, and then they often develop tumors in other parts of the body anyway, even after a double mastectomy. So it certainly isn't helping there. Perhaps they don't get breast cancer, but then they end up with lung cancer or ovarian cancer or some kind of a melanoma.
You're right, and I think that if they knew about what I just said, if they understand the fundamental concepts, they would at least have an alternative option in their decision making, where they might reconsider whether they would want surgical mutilation in an attempt to prevent cancer, or whether they would like to embody a more an overall diet and lifestyle that would protect their mitochondria and significantly reduce the risk for developing the cancer in the first place.
Great. And I guess my final question to you is this, again, for the individual out there who's already severely, possibly cachexic, they've already lost a tremendous amount of body mass. Can they achieve similar benefits with, let's say, some kind of an intermittent fast, possibly 24 to 48 hours versus, let's say, a longer therapeutic fast? Can they start to approach the levels of ketosis? Can autophagy come in at that stage? Can they get some of those benefits, or does it really need to be that week to 10-day fast?
No, I think every person is a unique metabolic entity,
Okay.
No, there are strategies, and this is what we call fine tuning the system. And a colleague of mine, Miriam Kalamian, who has a practice of helping a variety of cancer patients achieve success in managing their disease using metabolic approaches. She works with all kinds of cancer patients. Yeah, she has strategies for helping those patients that are very emaciated versus those that are not. So again, I agree with you. You can't take a person who is emaciated and doing very poorly and then put them on a 2-week therapeutic fast. This is not what anybody would recommend. It has to be done very, very gradually. You have to both break down the tumor cells while at the same time enhancing the health and physiology of the normal cells. And this must be done in a very gradual and strategic way. Otherwise, it could be counterproductive.
I agree, and I'm so grateful for you helping to share your knowledge with individuals out there. I certainly am not a big fan of chemotherapy. The evidence is overwhelming that it seems to cause more harm than good, particularly with the reoccurrence rates of cancers for individuals who've undergone some kind of a chemotherapy and radiotherapy. So if individuals do want to consider a more kind of holistic approach, fasting is beneficial. Even if the individual opts to have chemotherapy, the evidence is overwhelming that fasting helps. And today we've discussed the mechanisms. So Professor Seyfried, I'm really grateful. Do you have any final things to add, perhaps?
No, I think that I think basically the cancer field will change. This information is gradually seeping into the into the realm of knowledge, and I think more and more cancer patients will have the opportunity to make choices. And the chemo and the radiation have been with us for a long time, mainly because other potentially successful management options were not known, not understood, or were not available. I think this is beginning to change, and I think more and more cancer patients may be opting for less toxic and actually better, more effective therapeutic strategies.
I completely agree. One of the things that I've noticed is the sheer amount of content these days versus, let's say, 20 years ago, where important topics such as autophagy, are now being discussed and actually understood. This certainly wasn't the case before. And now, of course, there's a far better understanding of the role autophagy played, particularly when we compare it with the environment that we evolved out of. We didn't evolve in an environment where we had access to, 2,500 calories a day every single day. This simply wasn't part of our makeup, and our bodies, as have not fully adapted to the kind of industrial society that we have around us. So whenever we look for the cure to a disease, it's important to consider the context in which we came out of, so to speak. So I completely agree with you, and I'm very, very grateful that this knowledge is starting to get into, the mainstream of laypersons like myself, who are now starting to ask questions, and with the guidance of experts such as yourselves, are now getting answers. So thank you very much.
Well, thank you.
Thank you. It's been such a pleasure. And what I'll do, I'll stop the broadcast now, Professor Seatrade.